Dr. Henderson. He is Associate Professor of Psychiatry at Harvard Medical School, and he is a Director of Schizophrenia Clinical and Research Program. We had listened to his presentation yesterday. We enjoyed very much about his speech about psychosis, yesterday about the phenomenology and different approach to psychosis, and we are looking forward to hear from him about the relationship between obesity, diabetes, and mental health. Let us welcome Dr. Henderson.
Thank you. Good morning. So this is an important topic because it cuts across both medical problems as well as mental health, and it's a perfect example of the relationship between the two. And it's also, I think, something that's relevant to the Kuwaiti society, it's relevant to the U.S. society, and in many countries. There's there's been an incredible epidemic of obesity and diabetes, and that is trending upwards and almost out of control. So I think it's important. I want to highlight why we need to focus on this across the board, because at the end of the day, the obesity and diabetes lead to cardiovascular disease and the risk of cardiovascular disease. And we looked at data from our state in Massachusetts many years ago, and we found that our patients with mental illness, their cardiovascular death rates were 6 to 7 times higher than the general population. So they appeared to be at elevated risk, and it was primarily because of obesity, diabetes, and then there were some other leading to the cardiovascular disease. But there was also some increase in respiratory diseases, not surprising because of the smoking, right? High rates of smoking in the population, as well as infectious diseases. And we neglect to think about infectious diseases, but patients with mental illness are at high risk because of their behaviors and so on. So we have to be reminded of that. When you look at world populations, countries and regions, and you start looking at some of the medical classifications, we see that there's some differences, some subtle differences across the regions as far as physical activity, the mean range and body mass index. The fruit and vegetables are contained in the diet, and then you look at blood pressure and cholesterol. So across different regions, there may be some subtle differences, but overall, across the world, some of the trends are a decrease in physical activity, a decrease in healthy foods, and I'm going to show you examples of that, which of course have an effect on the lipids, blood pressure, and so on. And then when you start looking at people with mental illness, we see that patients with schizophrenia and bipolar disorder have higher relative risk for obesity, smoking, diabetes, hypertension, dyslipidemia, and metabolic syndrome. And of course, all of those contribute to cardiovascular disease. So it's actually not surprising that patients with mental illness will have increased death rates from cardiovascular disease. But it's also quite concerning, of course. We see a number of different illnesses that are elevated in people with mental illness that we need to be concerned about. Again, infectious diseases is something that flies under the radar. We once did a study at our clinic, and we asked every doctor in the clinic to tell us how many patients they have with hepatitis C or B or C, hepatitis infection. How many patients? And all the doctors, as careful as we are and as brilliant or whatever they classify themselves, we came up with 4 patients And it turned out it was 7% of our patients. We screened everyone, and there was 7% of our patients had a hepatitis exposure. And we knew nothing about it, weren't even thinking about it. So the notion is that we have to be thinking about some of the risks that our patients are subjected to because of the illness, because of the lifestyle, and so on. But they certainly are elevated compared to the general population. And then we looked across several states in the United States, and again found elevated rates of cardiovascular disease in every single state in people with mental illness. So very, very high risk. And when you start thinking about what are those things that are contributing to it, well, much of it is modifiable. We can do something about. Much of this is about behavior. Lipid abnormalities, diabetes, hypertension, metabolic syndrome, physical inactivity, and smoking. Those are all modifiable risk factors, right? We can actually do something about it, we can prevent it, and so on, and thereby changing the course of people's lives. And then there are things that also affect outcomes, such as access and utilization of medical care. There's significant data in the United States that patients with mental illness do not receive the same medical care that everybody else does. There's some barriers to providing excellent care, and then there's the adherence to therapies, economic capabilities, and limitations as well have an impact on people utilizing the system. But the major risk factors we actually can do something about because they're modifiable. And this is both true for patients with mental illness, it's true for the general population. We can do something about all of these risk factors. Some of the trends that we see that people are less likely to be treated for lipid problems, or their cholesterol is elevated, or even they have hyperglycemia or hypertension, they're less likely to actually receive the treatment. You can have one patient go into a doctor's office, have a cholesterol of 250, and the doctor prescribes a statin. So you take the statin, that's it. And then you can have a patient with a mental illness go to the same doctor's office, have a cholesterol of 250, and the doctor doesn't prescribe a statin. And why is that? And so we know that there are some differences in physician, clinician biases related to people with mental illness, and it actually can affect their decision-making process. Another study found that in the face of cardiac disease, patients with mental illness were less likely to see an angioplasty or coronary artery bypass surgery, even though indications were that was the appropriate treatment. And people, physicians, they can rationalize, well, they may not do well post-surgery, there's the reasons that they have reasons in their mind why they choose not to deliver the standard of care, but in fact it actually has a great impact. And of course, the use of aspirin as prophylactic, and that's why we recommend it, beta blockers, and so on. So there are some differences certainly in many studies that have been presented that suggest that the patients with mental illness from the medical side will actually suffer. One study done by Ben Bus in Atlanta used Medicare database and basically found that there was an increased mortality rate of patients presented to the emergency room with an MI, with myocardial infarction. There were increased mortality rates by 19% if they had any psychiatric diagnosis in their records. Any diagnosis whatsoever, increased mortality by 19%. And if they had schizophrenia, that was 34% increase in mortality. And it had nothing to do with the severity of the heart attack, because the heart attack is bad, and so they controlled for the type of heart attack, which vessel, AMI, IMI, whatever. But they found that it was based solely on the quality of care. So the quality of care changed just because of the psychiatric diagnosis. So we know, again, this is a real problem. Increased risk for these problems, and then not receiving the quality of care once these problems are detected. Now, this study actually changed how I practice. As we start to talk about diabetes and patients with mental illness, we were always quite good. We've been studying this for about 20 years, so we were always quite good at talking to patients about the risk and telling them to need to exercise and that sort of thing. And then I thought, well, okay, we have newer medicines that may have less risk for causing the diabetes and stuff, so that your numbers are tracking upward, and so we should switch you from your medication. And the patient would say, no, I don't want to switch. I'd rather stay on my medicine. I don't want to become psychotic again. I'm doing well. Now I go, okay, that's fantastic. Now I write a nice note, offer the patient to change, and I go home and I sleep well at night, figuring I did a good job. And then one day I got a call from one of my nurses at the clinic and said, Dave, I need to tell you that so-and-so died. And I'm like, what? And so this is a 29-year-old woman had been treated with one of the high-risk antipsychotic medications that can cause diabetes and so on. And she was the same person that like 3 years before that I had that conversation with. I said, you're tracking the wrong way, you need to switch. And she said, no, I'm not, I don't want to switch. And I said, okay, fine. But obesity, hyperlipidemia, hypertension, diabetes, right? Sent her off to a primary care doctor, doing the right thing, but she died from a heart attack at the age of 29. And then I realized that, okay, I can't do this way anymore. Like, if I know these drugs can cause these problems and the patients are tracking that way, I need to make a change. And so we'll describe what interventions can help. But you can't just sit by and watch patients go this way without intervening, because the outcomes are bad. This study shows that when it compares patients who had diabetes compared to patients who did not have diabetes, and it looked at a 7-year follow-up period for myocardial infarction, and I think these are people in their 40s and 50s, and they follow people. And so if you do not have diabetes, but you've had a previous heart attack, your risk of having a heart attack over that 7-year period was about 18.6%, right? Makes sense. If you had one heart attack, you're at risk for having another one. It's quite possible. But here is the most compelling argument, is that if you have diabetes and never had a heart attack, your risk of having a heart attack is 20.2% over that same 7-year period. So diabetes, having just the diagnosis, is basically saying, okay, you already had one heart attack. And so when I saw that, I said, okay, time to change. It's very predictive. These outcomes are very predictive, and I simply can't go along with it. Now, the whole picture leading up to the diabetes, cardiovascular disease, and so on is really this whole cluster of disorders that hang together, the basis of which is insulin resistance. Basic insulin resistance, it takes more insulin to clear glucose from your bloodstream because the cells, both hepatic as well as muscle, they're not as receptive, they're more responsive to insulin, they don't pick up the glucose as well. So the basis of it is insulin resistance, and then it's tied to the genetic risk, it's tied to obesity, hypertension, hyperlipidemia, and then there's contributions such as smoking. Smoking, in fact, people say, well, it keeps the weight off, but it doesn't keep the abdominal weight off. In fact, smoking is tied to insulin resistance, and smokers, skinny if they are, will still develop a little gut, and that's actually insulin resistance. And so this is what the insulin resistant or metabolic syndrome gut looks like. And it could be people who look relatively thin, but then my kids call it a BIF, which is a butt in front or something like your back side and front side. That's what my kids call it. And they keep checking mine like, Daddy, I don't know. But this is what it looks like. And even when patients don't look like they're gaining weight with some of these medicines, like if their weight itself stays relatively stable, they start to lay down fat in the abdomen. And that's where the risk is. That's where the metabolic risk is. Now, I put this slide in because it was a kind of earth-shattering to me that basically the message is, the take-home message is, it's easy to gain weight. And this points something out that actually was really disturbing to me, but I'm going to take an extreme case. Let's say if you take in an extra 125 calories a day, and you do that over a year. Every night you have an apple before you go to bed, and you don't burn it off, right? You lay down about 6 kilograms of body fat, just by that small error in energy balance. So 125 calories is not that much, right? 6 kilograms of body fat over a 1 year period. So that says, okay, it is easy to gain weight. Now this is unfortunate. This is the rate of childhood obesity is skyrocketing. You know, in the United States, everything went to the super size. We had about 15 years of super size. Like, okay, your hamburger costs $1, but if you pay $1.10, we'll double the size of the hamburger. Congratulations. So this is one of the major problems that we see, and we're starting to see in so many young people. And I'm reminded, just walking around here, that you guys have the same problems that we have. You have these fast food places. I mean, I thought, like, oh my God, they have a Krispy Kreme. Like one donut is worth a lifetime of fat. Like, and it's just one donut. But I thought, people running in to get their donuts, and so on. So you guys have the same problem that we have. There's, it's food intake and the types of foods that are available, and then people are actually using it. So we do know that there are some things to combat obesity, of course, and exercise is a critical thing as far as improving insulin sensitivity, improving glucose metabolism, keeping weight off, and so on. So if you exercise, your glucose metabolism is actually quite good. So I think that's one important thing, and one intervention that one must pursue, of course. Now, what do you see here? Right? That's like a missed opportunity, right? Everybody's on an escalator, but you would not believe this, but this is a medical conference. Cardiologists and endocrinologists, in fact. But everybody is on the escalator. So we have a problem with physical activity. We simply are not doing enough of it not like, I go to the gym. Going to the gym is great, but it's got to be how you live your life every day. Do you take the stairs? Do you, instead of calling down, like I love my office because when I'm in clinic, I'm up and down my office. When I can make a phone call, say, could you bring this? I'm like, no, I get up and I walk down the hallway. You guys see me running down the hallway all the time, right? That's an opportunity. Okay, I just burned off 2 extra calories doing that. That's fantastic. You can burn off like a few extra 100 extra calories, but those are opportunities that we, missed out on. And this is like, I couldn't believe this slide. They're going to the gym and they still have to take the escalator. Half a flight of stairs. That's absolutely ridiculous. But that's, we have to think about what's going on in society, in the mindset. And so, as we move towards talking about metabolic syndrome, we see that there are criteria for metabolic syndrome, but I caution you, if the trend you know, focusing on metabolic syndrome, I think it's a model that works for some populations, does not work for every population. So we have to be careful about it, but it at least reminds us that we need to address obesity, we need to address hyperlipidemia, we need to address blood pressure, we need to address glucose and glucose metabolism. But relying on the metabolic syndrome classifications in order to predict risk for diabetes and cardiovascular disease may be problematic if it's never been studied in your population. If you don't have those that clearly predicts it. Because, for instance, there's certainly some differences in criteria for metabolic syndrome around the world. There's differences in lab values, differences in waist circumference that we see. You know, at what waist does one's risk begin as it relates to metabolic syndrome? And it varies across populations, and even within them. You know, there can be some variation. And also, even the lipids, like some African populations, including African Americans, when in the face of insulin resistance, when they should have elevated lipids, the lipids are normal. When the triglycerides, you know, they're insulin resistant, we study them, and their triglycerides should be 200, and they come in at 100. And it says that that's great, but we actually don't know. Maybe the risk for cardiovascular disease begins with a triglyceride of 100 and not 150. So we really need to do population-specific risk assessments and develop risk models in order to do that. But this is what the insulin resistance looks like in the gut. The CAT scan, the slice of the abdomen. These folks were mapped for body mass index. Okay? So body mass index, it does not tell the whole story. So this person is insulin sensitive, and this person is insulin resistant. And all that white you see is fat. That's extra fat in the abdomen. And so you have to think about that. Let me just get this slide. So basically, the obesity impacts a number of other medical problems: lipids, cardiovascular disease, hypertension, increased risk of certain cancers, particularly colon cancer, reproductive hormone abnormalities, and so on. It causes a number of risks. So with persons with mental illness, you know, much more likely to have obesity. This has been seen everywhere. Certainly, even in major depression and bipolar disorder, you know, significant risk for obesity as well. Lifestyle factors, critical to this, as well as the contributions of the medication. And then when we start looking at psychotropic medications, we see that many medications make a contribution. So we have to be thinking about obviously what medicines are available. We have to advocate for better medicines, because what's nice is that all of these, like Brother told me, as a schizophrenia guy, a whole wave of antipsychotic medications have now gone generic, which means that they are in the process being as cheap as haloperidol. So then now it's not about economics, it's about choice. And so choosing the cleanest possible medications and making those available absolutely critical. But we see a number of drugs that are used at tips for weight loss. The bupropion, fluoxetine, not great, maybe early on in the process, but later on, patients may actually gain weight. There's some decent effect with anticonvulsants such as topiramate or zonisamide. Certainly, there's been many studies that have looked at this with mixtures on, but there's some encouragement. And then there's some drugs that are considered relatively weight neutral. And then there's some high-risk drugs that are known to cause significant weight gain. And as far as the antipsychotics, olanzapine and clozapine, by far cause the greatest amount of weight gain. And then there are drugs that are kind of in the moderate category. And then but a drug, we look at over here, antipsychotic, like a drug like liprazidone, probably one of the most weight neutral drugs. It's now available, it's now a generic medication. So you know, if you can obtain that, then you have a good choice of medications. So this leads us to kind of the diabetes story. I'm not going to go and spend my time talking about diabetes itself. People know what it is, but significant medical consequences of it is tremendously high. And if you look over time with the natural history of diabetes, we see that well before a person develops diabetes, even 10 years before and counting, the beta cells start to decline, and their insulin levels start to tail off, and their insulin resistance actually goes up. So well before people develop diabetes, the clock is already starting to tick, and if you study them, you can actually see that they are at significant risk. And so the beta cell function just gradually declines over time. And what we see with some of the medications is that instead of people developing diabetes in their 40s and 50s based on this decline, the medication pushes it back and they can develop it in their 20s and 30s and maybe even adolescence as well with the effect of these medicines. So again, this highlights the fact that over time, it's the beta cell function decline that will start to tip people into hypoglycemia, but it takes years to actually get there. Now, probably, I think one of the most important relationships between diabetes and mental health problems is depression. Depression is more common in people with diabetes, and certainly can interfere with the care and self-management of the diabetes. Older adults with diabetes incur higher mental health costs than those who are not depressed. So again, if you don't address the depression, the outcomes are going to be far worse, and the costs are going to be far worse as well. So older adults have high rates of underdiagnosis and undertreatment for depressive symptoms, poor outcomes of diabetes care for patients with unrecognized diabetes. So it's absolutely clear that it's important to pay attention to this. Depression is more prevalent among adults with diabetes and have a higher recurrence and longer duration of major depressive disorder and depressive symptoms. Higher odds of functional disability with comorbid diabetes and depression, and major depressive disorder predict the onset of diabetes as well. So it's almost, it's saying each may increase the risk for the other. Again. So a meta-analysis of 42 studies concluded that the presence of diabetes doubles the odds of comorbid depression with higher incidence among women. And another meta-analysis also, in a large retrospective study, found the same results. So significant data that ties the two together. Diabetes places a unique burden of invasive blood monitoring, diet, and exercise, resulting in greater prevalence for depression compared to those with chronic illnesses. So, to manage diabetes, it's a great deal of work, but depression alone can contribute to developing diabetes, but it also, the depression can interfere with the monitoring. And then there's the effect on cognition as well that we have to be concerned about. The risk of comorbid cognitive loss and diabetes is greater in years past due to the increased mean of age of individuals with diabetes. So the older you get, and then you add diabetes on top of it, then there's an increased risk of cognitive impairment. So better glycemic control equals better cognitive function. The wrong daughters. When certainly hyperglycemia, cognitive problems can occur with hypoglycemia, but those actually resolve with prompt treatment. Cognitive impairment does not necessarily worsen the mortality rate for people with diabetes, but it certainly worsens the functioning and quality of life. So, ways for intervention, certainly education is critical. Social support, being married, decreases the risk for depression. So everybody who's not married, please run out and get married. Having accommodations for functional limitations, interactive rather than didactic training. So educating families, but involving and not just simply telling them what to do. Drug therapy in combination with behavioral treatment, more effective than prescriptions alone. Dr. Howard went through this. But again, it's a treatment which I think is absolutely critical. Now, so we have diabetes as a problem, and then we have patients who are taking antipsychotic medications, which cuts across bipolar disorder, psychosis, schizophrenia, even depression as well. But what we found is that there are certain antipsychotic medications that cause insulin resistance unrelated to weight gain. And then we did a study many years ago that found that medications like clozapine and olanzapine cause insulin resistance in patients. And we looked at patients who did not gain weight with the medicine, so their mean BMI was about 25, which is actually quite remarkable for our population. But if they were on clozapine and olanzapine, they were insulin resistant. Just by being on the drug, nothing else. And so there were some drugs that infer insulin resistance no matter who takes it. And I had one patient, a college student that was in this study, who ran 6 miles a day. And I thought if there's one person, she's on clozapine, great responder, MIT student, but she ran 6 miles a day. I thought if there's one person that's not going to be insulin resistant, it's this person because of her exercise level. And sure enough, she was insulin resistant when we studied her. So really, really alarming. And so when you look at the effect of the potential for development of diabetes across these medications, there are some drugs that aren't contributing to the risk, but there are some drugs that are critically increasing the risk for diabetes, such as by far clozapine is the worst, and olanzapine. And I have to run a clinic. We have about 200 patients on clozapine. I love the drug, but we work hard to try to keep them medically healthy. Constantly, kids are constant, and it took us a number of years to figure that out. And when I developed the clinic back in 1992, I put in a tracking system because out of the first 10 patients, I think 4 of them developed diabetes on a short period. I thought, this is crazy. And so we've been tracking our patients since 1992, and I'm just about to look at the 20-year data. But the 10-year data was so alarming that we completely changed what we do because we found, the 5-year data said a third of the patients developed diabetes, and by the 10-year, we started to get the cardiovascular effects. And so we found elevated rates of cardiovascular death, mean age of 35, there's a 9% incidence of death from a heart attack. And compared to the general population, it should have been about 1%. And then we also found that high-risk populations, they have high risk for cardiovascular disease and diabetes, and here with African American and Hispanic patients, dramatically elevated risk as well. So with the 10-year data, like, oh my God, so we completely changed what we do, and we are so aggressive in trying to prevent these medical problems with these patients. The big story was the diabetic ketoacidosis, which is the severe hypoglycemia, which patients have died from. And so when you don't do glucose monitoring, mostly with clozapine and olanzapine, you miss these cases, and patients can actually die from the diabetic ketoacidosis. And we were trying to think of what was it that, is it the drug suddenly, dramatically shut down the beta cell, so that, and then people go into hypoglycemia, because DKA is actually an unusual event, just out of the blue. And it turns out that we looked at our hospital database, and I took 2 groups. One group of patients with schizophrenia who had a history of diabetes and then experienced diabetic ketoacidosis, and another group who did not have a history of diabetes but wound up in emergency room with diabetic ketoacidosis. And in trying to figure out, how do they get there in such a short order? And it turns out that the people without a history of diabetes, but went into DKA, all of them were on clozapine and olanzapine. But their mean hemoglobin A1C was almost 14. And so what this says is that they had diabetes for weeks, months, or years, and nobody checked it. Nobody actually screened for it. And then something tipped them into DKA. You know, it could have been a urinary tract infection, which is typical for type 2 diabetics, or one person had appendicitis or whatever, but nobody checked the glucose. And these people were walking around with diabetes for years, and a couple of them ended up, you know, dying from cardiovascular disease. But they probably had it, like, you know, for years, and nobody was actually checking. So we know with these antipsychotics, there's relative risks, and you need to practice based on those relative risks depending on the individual. And this is a bunch of the atypical drugs, many of which, I think all of these drugs are now generic with the exception of aripiprazole, which will be generic, I think, in next year or the year after. So you have some relatively clean medication, but what we do know is that you have to monitor and you have to intervene, and you have to be aggressive. Like just like the hospital here, we have a gym in our building where our clinic is, and I haven't done this in a while, but when we were, you know, trying to get patients to use the gym, the first thing I did was I got the staff to use the gym. So I focused on my staff and cleaned up all of our bad habits that were visible to us. If we're going to get our patients healthy, we have to be healthy, and we have to show them. So we all started going to the gym. People started walking out with bottles of water and so on, and so we got healthy. And then we would, you know, see our patients down in the gym, and you know, they would motivate us, we would motivate them, and so on. And we kind of changed the culture. So you can't make recommendations to people, things you don't believe in. Like, if you're a doctor and you're smoking, and you know, how good are you going to be at convincing that patient to stop smoking? You're like, well, okay, oh, you tried, fine, that's okay. It's really tough, I know. And you're done, but that's not what gets people to stop smoking. So you have to also, it's not just about our patients, I think it's you know, everybody, healthy lifestyle, and it's just getting started, doing something. Plenty of literature, you decide what program you want to do, and just do it. Doesn't matter. There's no data that says that one diet or one approach is better than another approach. The only thing that matters is how long people stay with it, right? It doesn't matter what you choose to do, it's how long you actually stay with it that has an impact and outcome. So simple recommendations, you know, modest changes. Because I can tell you, in the 5 days I've been here in Kuwait, I think I put on 10 pounds. So it's modifying the cultural, you know, norms and behaviors and what you do and stuff, and putting that in the context of, okay, everybody's got to, you know, get healthier and lose weight and so on, and particularly with our patients, but modest lifestyle changes work better than dramatic changes in diet and so on. But the good news is, if you do anything, if you have an impact on any of these things, patients get better. You reduce their cardiovascular risk, you extend their lives. If you address their lipids, you tell them to take omega-3 for your triglyceride, you can extend their life. Any of those, any intervention can have an impact. No intervention doesn't have an impact. So it's, you know, the goal is to keep patients medically healthy, and psychologically healthy, healthy lifestyle counseling, intervention right from the start. I do it in every patient who comes into my office. I put them on a scale.